right, so we're going to talk a little bit about why do the goalposts keep moving? What is the correct target? So I was very lucky to find some of these cute little figures on Google, but when thinking about this talk, it really just gave me a perspective on how we've been treating IBD, how we've been analyzing our different treatment targets, and really questioning that the way things have moved forward may have been flawed, and we might have not given certain medications or certain therapies the chance that they should have, and maybe we were selecting out the wrong patients, and I'll explain all of this as I go along, but if you can think more from the bleachers rather than being very specific in this, I think you'll understand where my talk is going. All right, so one of the things that can distinguish what the outcomes are for patients is how you practice your medicine. So, you know, it's always the 8 ball. So on some level, we may be chasing the 8 ball, and so that would be the patient where we respond or we react to their symptoms and therefore make decisions as part of it. Or you might be the type of person who's trying to stay ahead of the 8 ball, and so that really philosophically would mean that you're a more proactive person, and the way that you would analyze your treatment and your patient's response would be very different if you thought of just reacting to what their symptoms and what their different types of results of their lab work and their endoscopies may be. So as we're going through the talk, I want you to be able to analyze, and I don't know, maybe we can make this as part of one of our questions. Are you more a person who stays ahead of the game, meaning proactive, or are you more a person who's reactive? And so I'd like to then present what this talk is about. So, you know, I consider myself fortunate in some ways that I actually began my livelihood in pediatric GI with very few medications that treated IBD. And just to tell you, Joel and I are the same year, okay? And so early on, that what? Oh, well, you know, the hairdresser knows for sure. But, you know, what did we have in the late 1980s, 1990s? We had these poor patients who were in the hospital who were steroid dependent. They were on TPN. They were on IV steroids, and, you know, we really didn't seem to make them much better. In some ways, a little bit better, but in some ways, not much at all. And these would be the kids who would have all the complications of steroids in that, you know, they would be cushingoid, they might have hypertension, they'd wind up with avascular necrosis, and their overall disease course was a disaster. But nowadays, we have these beautiful young men, and this is a patient of mine who is an avid hockey player, who only in his entire course that I took care of him saw steroids once. And so this was a young man who did beautifully well on thiopurines and managed to be a fantastic hockey player, went on to Boston College and played for them. And so I got the perspective in knowing how life used to be and then how the different medications have changed the way we take care of kids now. So I started thinking about this, and when you have a patient who comes into the office, there's basically 3 levels of consideration that I put in my head. So mom or dad brings you their child, and what's really the most important thing to the patient and the family when they're first brought to you? Well, you want to make the patient feel better. Hence, that would be something called clinical remission. The next most important thing is you want to know that the healthcare provider does a good job, and so the labs look better, and then the healthcare provider feels better, and then the patient feels better, maybe the parents feel better. But really, what's the most important thing for the disease, not only short-term, but more importantly, long-term? And I would say that you have to make the mucosa look better, because a healthy GI tract overall, we're not talking about functional, we're just talking about straight up inflammatory components, will then tell you that you're probably doing the best job for the patient, not only in the acute setting, but what the long-term consequences of that may be. So we've seen this chart many times, and I think it's actually a great thing sometimes to show parents because, you know, understandably, they're very concerned about putting their kids on medications that might suppress their immune system, that might give them lymphoma, that might be a poison. And so they hesitate and they hesitate and they'll go to different providers, and they'll try different different complementary strategies in order not to put them onto a medication that is written about in the media about causing lots of problems. So if you explain to them that IBD is really a disease of a lifetime, and that in the very beginning it's inflammatory, and then as the disease progresses, in other words, it's either undertreated or not treated effectively, then you go from an inflammatory state to a penetrating or stricturing. And I tell them, no matter what medicine is great today or that will ever be invented in the future, no medication will be as effective on a fibrosed or scarred down tissue as it would be with inflammatory tissue, which has fresh and an ability to respond. So with that too, is the understanding, although this is about Crohn's disease, is we also know that even in patients where you have them with adequate treatment, that this is not a disease that's just flatline as far as its activity. It's a relapsing, remitting disease that even in patients, in that same patient, that something happens at different periods of time, either during the year or during their lifetime, that changes the activity of the disease. So I explain to parents there are 4 times a year that I know my number of phone calls for IBD are going to go up. Somewhere around August, September, around December, around May, June, and then the anniversary season or date of when their child was first diagnosed. I could tell you that school and holidays may be part of it. It may also be for certain time periods. Maybe there are different types of diets that one eats. Maybe there's a difference in sun exposure. But those are basically the 4 times that I know that I'm going to get more phone calls. So again, it's a disease that progresses over time if undertreated, and it does have the ability to have different activity rates, even in the same patient, either in a year or over time. Now, our current therapies are as what you see here. For aminosalicylates, we certainly use it a lot for ulcerative colitis, but the data are very poor as far as Crohn's disease. Occasionally, we'll use antibiotics in the idea that there may be some ability to manipulate the intestinal microbiome and then maybe take off that inflammatory load that some of the bacteria may put on the mucosa. Steroids are great when you need to put out the fire, but at the end of the day, you certainly don't want to use it long term, and the minute you start it should be the minute you think of your exit strategy. But we now have some new corticosteroids that are available that have a very high pass metabolism that may at least minimize some of the side effects that we saw with the usual types that we know of. Immunomodulators, as they call steroid-sparing agents, have been certainly something that has moved forward both adult and pediatric medicine about our ability to stop using those steroids as much. And we certainly have the person in the audience who helped us with a re-understanding how we should be looking at therapy. And then the biologics, which really did not come out for more use really till the late 90s, till the 2000s, have really changed the way that IBD behaves itself and how we now as practitioners take care of our patients. So we have many different monoclonal antibodies, and I want to remind anybody who loves words that anything that ends in a MAB stands for monoclonal antibody. You can understand what type of antibody it is by that middle syllable. So if it's something like infliximab, it's chimeric. If it's something like certolizumab, it's humanized. And if it's adalimumab, then it's human. So that goes for almost all monoclonal antibodies, even for those that our oncology colleagues use. So we have these biologics, and now our immunomodulators, which we thought of as being steroid-sparing agents, now might be thought of as being used as biologic optimizing agents. So DeHanes in 2008 really brought this top-down, step-up therapy. So the pyramids weren't just those that we knew in Egypt. It became a very different conversation when it came to IBD. But as most of us who are not millennials know, that the way we were originally trained is you first started out with your aminosalicylates, some antibiotics, and you went to steroids. Then if you constantly had to use steroids, you went on to immunomodulators. When that didn't work, and who knows how many months or years down the line that would be, you'd finally do the Hail Mary and you give them a biologic, and if that didn't work, you sent them on to surgery. Nowadays, there is a different understanding of maybe how we should be using this. So DeHaene showed that in patients with Crohn's disease in 2008, that was reported in The Lancet, that maybe there should be a different strategy, and perhaps the patients who are at greatest risk should start with the biologics and then go further. And what he showed that in patients who were compared versus step up versus top down, that at 2 years that the patients who were on step up, only 30% of those had mucosal healing, whereas those who were with bad disease 2 years later, when they had the top down, about 70% or so actually had mucosal healing. So that was really the first indicator that maybe what we were looking at strategy-wise needed to be rethought. So what should be the target? What should be the targets? We have many different considerations here. Should it be clinical remission? Should it be steroid-free remission? Should it be deep remission? And we'll talk about what that means. Should it be histologic remission? And how do we get there? There are so many new or even old medications that we have to get us to that point. But, you know, enteral nutrition, we've talked about that. And the latest thing that was reported in the New England Journal of Medicine in mid-March was something called SMAD7 antisense oligonucleotide, something called Mongersen. And what that really should just bring to us is that, you know, what we're able to do now is instead of throwing steroids at someone, which is sort of like a wet blanket, we now are able to have these new medications that are more targeted. And so some of the side effects that we saw with our earlier medications may be avoided if we really know who was the person that would do well with SMAD7 antisense, or somebody who would do well with the alpha-4 beta-7 anti-integrins, or maybe somebody would do well with a P40 IL-12/23 antibody that could help them. So I think what we really need to understand is that we need to understand who that patient is, and so how do we do that? Do we do it by genetics? Do we do it by serologic markers? And then if you choose a therapy, you know, how do you monitor that? Do you understand somebody's pharmacokinetics and maybe therapeutic drug monitoring? So that all these things out there, I meant to put it on the slide just to get you thinking about all the different considerations of how we're dealing with patients. Do we do the worm eggs? I mean, that's really very interesting. Is there something about having your system primed in a different way that maybe your IBD would respond differently? So there are a lot of new targets out there, a lot of new medications that are being developed. But how should we do this? So years ago, the mainstay of therapy, as you knew, were steroids and antibiotics and mesalamines and TPN. Maybe that kept the patients out of the hospital. Who knew? You hoped to reduce some surgeries with it, and you had some symptom resolution and maybe some laboratory improvement, and we called that clinical remission. So the patient was feeling better. Maybe some of your lab work was better. They had decreased bowel movements. Maybe their abdominal pain was better. And a lot of the early studies were all based on clinical remission, and we have many indices, which we'll talk about in a minute, that allowed us to understand that we were getting somewhere. And that was a good thing to start off with. In the recent past, again, we started using more immunomodulators. So instead of just having the patient feel better, we were feeling bad that they were having all the consequences of steroids, that with the use of the immunomodulators, we were keeping patients out of the hospital a bit more, maybe because the steroids were in some ways making them worse just by the steroid itself. Maybe we were reducing some of the surgeries, maybe on the short term, but probably on the not the long term. But for sure, what we were doing is we were getting to the point where we could look for corticosteroid-free remission. And so that became another target. So patient feeling better and a patient off steroids. So those were the types of goalposts, if you will, that we were looking for as far as our efficacy of both medications and other treatment strategies. Well, nowadays, certainly with our ability to look at the mucosa in more detail, by doing more ileocolonoscopies, by using capsule endoscopy, to be really having now the ability to look at the mucosa, we were able to show that although our immunomodulators were keeping them off steroids, and maybe there was some mucosal healing, we weren't seeing that rapid improvement in the mucosa. So what started happening with the advent of using monoclonal antibodies is that some of the things that they were looking for in secondary analyses were, well, what's happening with the mucosa? And what was incredible in the early stages of introducing this medication is that you went from a horrible-looking endoscopy to actually one that showed incredible improvement. And you said, oh my goodness, well, is this new type of strategy able to improve somebody's mucosa that quickly? What does that mean not only for the disease as far as their acute presentation, but what would happen long term? If I kept that patient, that one who responded so quickly, what would that mean for them in the long term? So then we started saying, well, you know what? Maybe mucosal healing is something that we should be looking at. Maybe it should be something ultimately that we should be targeting for. And it's only really recently that we've actually put that more into our analysis of what medication or what treatment strategies should work well. A deep remission actually goes a tiny bit further in that not only does the patient feel better, not only is the patient off steroids, but then when you look in with the endoscope, whether it's above or below, you actually see either near or complete healing. So that was something that really made a big difference. And the question would be, is how far do you push your treatment strategy to achieve that? Because there's always risks and benefits. How much do you give them as far as medications that affect their immune system to get to that? And that's really something that you contemplate. But it also makes you think, when you look back on all of the studies that have been done in the past, and they were done as well as we would have hoped, do you then go and ask yourself, well, is clinical remission enough? And maybe those medications should have worked better if mucosal healing was a target, or maybe the fact that they didn't work was because we weren't looking at the right patients because our clinical indices confused us. So that brings about what's clinical remission. Well, there are many different indices out there. There's the CDAI, there's a PCDAI, there's the UCAI, there's a PUCAI, there's a Harvey-Bradshaw, and they do have some elements that are objective data. So a hemoglobin is a hemoglobin. But when you look at some of the subjective measures that some of these indices have, you can understand how they can be flawed. So the number of stools per day. So if you have somebody with bad IBS, forget about it. You can blow through the roof and have a high CDAI or PCDAI. Abdominal pain. I have some kids who have the most wicked IBD. I go in, I scope them, and I say, I don't know how they're walking around not in significant pain, but they have no pain. And then you have somebody who's just got a little something or whatever, and they're in enormous pain. It's not to either make the person who can tolerate pain better than the other, but it does impact the indice scale, and so that's why I really want you all to think about that. General well-being. Well, I got to tell you, general well-being, Monday morning, I'm not the same general well-being I am on Saturday morning. I got to tell you, I'm way better. So, again, just telling you how it's so subjective. And then for the adult studies that the indices, that is, they can use opiates. And so, you know, what is tolerable for one person where they need to take an antidiarrheal versus someone else? So again, just bringing into mind that when all of the studies are put together, using clinical remission may be an index that can be flawed. So just taking a look at Lopez, and this is actually something that is ahead of print from January, but what he did is he looked at patients who were in clinical remission with ulcerative colitis, and what he showed was that in patients who were either on adalimumab or infliximab, that there was an improvement in how they felt, and that seems great. So what you may say to yourself is, why did adalimumab not work as well as infliximab? Well, one of the reasons may be is that more patients who were on adalimumab had not been biologically naive, and so that may have shifted why their meta-analysis may be a bit different, but showing again that the biologics actually show clinical remission. So then now we go on to steroid-free remission. So how much is steroid-free remission? Is it biologic facilitated? Is it immunologic facilitated? I should have probably put in there, is it diet facilitated? Well, Jim showed us that 6-MP does maintain remission in patients with Crohn's disease, and he was able to show that over a period of time, if these patients were put on 6-MP, If you followed them over time, that those who are not on it, and there was some steroids in this study too, showed that those who did well after 18 months were more likely to be on 6-MP and doing pretty well versus those who had been taking placebo. So again, telling us that there was something important about immune manipulation and being able to do that so you could reduce the exposure of patients to steroids. Hanauer looked at patients, again, at the Accent 1 study for Crohn's disease, and he was able to show that if you took the patients who actually responded after the first dose, and you were to group them into 3 groups, so group 1 got placebo, group 2 got 5 milligrams per kilogram, and group 3 actually got 10 milligrams per kilogram. He was able to show that after they went through the induction period and went on to the maintenance phase, that you were able to achieve steroid-free remission in those patients who responded well in the first couple of weeks. And I remind you again about this whole idea of responding early and what maybe the durability of that response may mean over time. So endoscopic remission really tells us, what's going on inside the colon. So here we have a patient with typical Crohn's disease, another with ulcerative colitis, and if you were able to show healing, and I want to again say it means healing, not healed. Okay, so a lot of the studies are just looking for mucosal healing. What are we looking for? We're looking for that beautiful, pristine colon with the lovely folds, with the vasculature so pronounced. And that's what we really would like. So again, endoscopic remission, mucosal healing. So mucosal healing, as of today, we really don't have anything that is completely validated for either Crohn's or ulcerative colitis. What does it mean? Does it mean healing or healed of the mucosa? It's used often as secondary endpoints in many of the studies. I want you to think back, too, that when you think of ulcerative colitis and you think of Crohn's disease, ulcerative colitis, as we know, is a process that's really in that first mucosal layer, and that tends to be starting from the rectum and going backwards. But what do you think about the patient who has Crohn's disease where you have skip areas and where it's transmural? So can you really as effectively use mucosal healing in the same way that we look at for ulcerative colitis? I'm not saying that you can't, but it's a way that you have to consider what mucosal means for each of the 2 entities. So, again, we look for looking at the mucosa directly, but if you have somebody who strictly has small bowel disease, then you could get to it certainly by capsule endoscopy. You may have some reflection by any of our imaging studies, but you can't biopsy the mid-jejunum. So, again, just understanding that when you think of mucosal healing, these may be some of the issues of how we get to that point. So clinical remission is another indicator, and so there have been several studies, certainly from Jataid, where several studies have demonstrated the poor correlation between clinical remission and what you see endoscopically. And so again, looking back, that maybe there should be other things and not just clinical remission to look at how patients go. And just because someone feels better on therapy, obviously it means that's great for them and less phone calls for you, but it should not bring your guard down to say that their disease is under control. So mucosal healing has now become a key endpoint, and the FDA has asked that for any new treatment that be part of the design of the study for IBD patients. So this is a slide that is not meant to make you crazy, because I'm sure other things in life do, but it's basically looking at endoscopic evaluation. And again, there are many things out there. The first 2 are about the Crohn's disease evaluation of endoscopic healing, but there are many out there, and there's a lot of benefits from it in some ways, but a lot of pitfalls in how we do this, and yet there's no standardization. And remember, too, mucosal healing really is in the eyes of the beholder. So, just like any picture where someone says, oh, that looks pretty good, or that one looks, well, it's not that much better, you have to understand that mucosal healing still may be something that might have a subjective component. As far as ulcerative colitis, the Mayo score has worked quite well, and I think these are 4 nice distinctive pictures, but we don't always get patients that fit beautifully into either of these categories. So again, saying that it's important to have that, but nothing is perfect yet. So endoscopic remission, there are some associations. You can have prolonged clinical remission if you make the mucosa look better. There's less rates of hospitalization and decrease as far as surgical resection. And this is, again, from Lopez's paper where he looked at induction of mucosal healing with ulcerative colitis with patients who are on biologics. And the bottom really tells you that in those patients who are on biologics, they tended to do better if they were induced. That looking at maintenance, again, looking at adalimumab and infliximab, again, they tend to do better overall. Again, just saying that those patients who are on adalimumab tended to have been exposed previously to infliximab, and perhaps that's why there's a bit difference on that particular picture there. But you can see that overall that they do better. And again, looking back on a post hoc analysis of Act 1 and Act 2, that if you responded within the first few weeks, that it was more likely that at 6 months or even a year out that you were more likely to do well if you had mucosal healing. So again, showing you that perhaps mucosal healing is something that we should be looking towards, and it may allow us to have some understanding prognostically that that patient will do well. And looking at the surgical rate, so this was a Norwegian study where they took a look at both ulcerative colitis and Crohn's disease, and you can see that in the green bar, or I should say green part of the graph, you could see that in those patients who achieved mucosal healing tended to do better in having less surgery than in those patients who did not have mucosal healing in both ulcerative colitis and Crohn's disease. And again, just looking at hospitalizations, that for ulcerative colitis, if you look at the 2A, meaning colectomy rates versus those who are on combined, it again shows that there is an impact when you get somebody into remission. Now, looking at some of the others, looking at the severe endoscopic lesions, how does that predict it? And again, if you had severe disease in Crohn's and you had really bad deep ulcers, you were more likely to have surgery than those who did not. And the complication rate sort of being the same reflection of that, that when you had severe disease, that you were more likely to have complications. So now the clinical practice treatment has changed a little bit. The strategy now is treat to target. So there have been a number of guidelines that have been put out by the AGA that has looked for maybe clinical decision making to not only look at just making the patient feel better, but there may be other objectives. So it pulls both the clinical symptoms as well as some objective inflammatory measures into the practical algorithm. And so perhaps we should be looking to treat patients that are appropriately to treat to target. And this is just one example from Sanborn that was written for the AGA guidelines. And if you can see that it both looks at some of the clinical parameters that we do every day in our practice, adding some objective measures, and then being able to perhaps change the way we manage our patient this way. So what would be the future target? Well, you know, we say that if somebody's mucosa looks better, but could it be to the point where our medications and the targets of that are so effective that we can go from histologic healing? So histologic healing meaning look under the microscope and seeing them go and have complete improvement. So medications that are being developed now, and there will be a lot more in the next few years, and so we're really in a wonderful time period where we may be able to characterize both from their genetics as well as their endoscopy and maybe some of their serologic values of picking out a particular medication that might be right for the patient. There are certainly small molecules that are our targets now. Intestinal microbiome, which we had a wonderful morning looking at how that may be part of our practice and maybe manipulating that with antibiotics, probiotics, and fecal transplant, and then gene therapies. So what should our targets be? I think at this point we still need to take care of the patient, make them feel better. We certainly want to take them off steroids. We want to try to get to mucosal healing with the balance of not harming the patient to get to that point. Perhaps with some therapeutic drug monitoring, we can have a bit more understanding of how we're using these medications and how it affects the patient, not only for them just by themselves, but over time. And so what's our ultimate target? Well, what we really want to get to is a cure, and that would be something that I would love to see within my lifetime. But until we get there, I think we need to be responsible about focusing on what is really making the patient better and using objective measures to get there. Thank you.